There was one particular question, an image based on colonoscopy, which showed those flimsy membranes. It's a pseudomembranous colitis. I've already made a presentation on this, targeting only the MCQ, but now I thought I'll make a brief about the pseudomembranous colitis, and this is in collaboration with Professor Reva ma'am. And at the end, there is a case discussion from my personal collection. So this Clostridium difficile, now it is called Clostridioides difficile. It's a gram-positive spore-bearing obligate anaerobe and cannot obviously be easily cultured. Anaerobes, they have difficulty in culturing them. And it is a normal commensal in the human intestine. When for some reason the bacterial flora has changed, either because of immunocompromise or because of age or because of the antibiotics that you have given, these commensals become pathogenic. And the toxicogenic strains have A and B. You can have strains which do not have toxin. And they can be grown on blood agar. You get these white fluffy colonies. And here you have these gram-positive but spore-bearing. The inset shows the spore-bearing. Now, please don't run through this slide. I have kept it as a clinical pathway. The moment you run through the slide, you will not know when they ask you an MCQ based on the management, you will not know what to give and you will try to mug up. There's no need for mugging up. Now, how do these patients present? Mostly in an ICU setting. They can have diarrhea, fever, melena, abdominal pain, features of peritonitis, or even features of sepsis. Simple. Now, this patient may be admitted with a head injury. He may be admitted for post-operative care, major cardiothoracic surgery, and is for a post-operative care. Or he may be admitted with a pneumonia, but he will be developing abdominal signs and symptoms. Let's keep it very simple. Now, if they are going to have all these symptoms and signs, how will you choose the investigations? Let's go from the most simple. Suppose patient has only diarrhea. Send the stool for routine and toxin A and B because they are in the ICU setting. Now, most of them are not going to get symptoms in isolation or findings in isolation. Keep that also in mind. You find toxin A and B and patient has only diarrhea, you can do a medical management. We'll come to it. Now, what if they have a melena? Again, you send for toxin A and B in a medical management. What if they have abdominal pain and peritonitis? Now, these are the red herrings to say something serious is going on surgically inside the abdomen. So, you will think of imaging plus or minus colonoscopy. So, you do a plain X-ray, you'll show a dilated colon. You cannot make up your mind with the plain X-ray. You will move to a CT abdomen, which will show the accordion sign. I'll come to all that later. If your CT shows free gas, now no need to look for other findings. They will straight go to surgery. That means they are perforated. If your CT shows accordion sign and a pneumoperitoneum or a toxic megacolon, you will move to a surgery. Because this toxic megacolon is just one step short of perforating and becoming a pneumoperitoneum. You will go for a surgery. Now let's look. Suppose they come with a sepsis. Look for a cause. You might have diarrhea and the patient might have abdominal findings. They will be moving into this algorithm. That means they'll be moving towards the surgery algorithm. Now, in the medical management, it's not that you just put medical management and forget. No, you need a careful observation because they can deteriorate. They can be very simple diarrhea can move into an abdominal severe problem. So once they deteriorate, you will take for imaging and surgery, or based on maybe your clinical findings are so clear cut at that point, you might go to surgery without wasting your time on unnecessary imaging also. So please keep this diagram in mind. Very simple. You will try and use simple investigations, try and use medical management, but observation. The moment things are getting sinister, start using more intensive investigations like your imaging, colonoscopy, etc. Now, this is what you will find in your accordion sign. In a plain X-ray, you might find only dilated large bowel. But when you do a CT, you will find something known as an accordion sign. This is your cecum, and you can see these horstrations so clear here, like your accordion. And lot of bowel wall thickening will be there. Submucosal edema will be there. This is your accordion sign. Much better seen here than this image. Now, this is from Dr. Nirmala Banerjee from Calcutta. You do a colonoscopy, you will find these pseudomembranes. We have talked about it in our previous presentation. If they take a biopsy from these, what would they find? Have a look. I'll draw. These are your colonic mucosal wall. You have your glands. Fine. But have a look here. This is intense inflammatory exudate, almost bursting out like a volcano. Neutrophils, severe exudates. They are bursting out from this. They are bursting out from here like a volcano. So this is known as a volcano sign, classic of pseudomembranous colitis. Okay. Now, how do the course act? Alteration of the gut flora. Patient is hospitalized, he is on antibiotic therapy. Exposure to C. difficile, contaminated hands and environment. What are the clinical factors? Most important is antibiotics. And in the antibiotics, clindamycin is the main culprit. Penicillins and cephalosporins also. Now, acquisition of C. difficile, and as I told you, it can lead to frank colitis, leading up to it can resolve, or it can go into surgery and even a recurrence, or they can just sit there as asymptomatic colonization. This is your timeline for difficile infections. So they get in, there is an altered flora, still they may not cause a problem. They may sit there quietly, or they may go into the very fatal phase needing surgery, and they may even recur. They will respond to medication and they may even recur. So this was one of our patients. You can make out very sick in the ICU, severe abdominal distension. Along with that, we have features of peritonitis and sepsis. This patient in the ICU, for a reason not for the abdomen, for something else, she's in the ICU. 2 weeks of antibiotic she has got. She's in the ICU, you can see the airway support. She's got 2 weeks of antibiotics. Because of features like this, we have taken an X-ray. You will only find dilated bowel. You will not find anything else on a plain X-ray. But you will see that the large intestinal lumen is more than 10 centimeter. More than 8 centimeter of the large intestine should tell you that this is probably going to toxic megacolon. Toxic megacolon has its own issues because it will perforate. Now the same patient, when we did a CT, you can see the accordion sign very well. Let's see what we found in laprotomy. This is the dilated sigmoid and the descending colon. You can even see a dark patch which has already is a necrotic patch. You open, you find this, look at the membrane. Swathes of membrane can be there. In the diagram which I showed you first, there was only specks, but the whole thing can be see swathes. You can see skip lesions also. Multiple bowel is being opened to see how long the problem goes on, so that you need to get a healthy bowel to anastomose with each other. Finally, we had to sacrifice this much of bowel. Now, it can be grown in culture. but it is very difficult because it's an anaerobe. So you have various other clinical modalities. You can look at the toxin level. You can look at the DDH assay, which is the enzyme, or you can do a NAT or PCR. And you know this has got a high specificity, but low sensitivity. And these two have a very quick turnaround time so that you can easily start your medication. Of course, they have their disadvantages. You can go through this slide at your own pace. Now, risk factors for acquiring C. difficile. Most important is antibiotic exposure. That is why they will tell you this is a colonoscopic finding of such and such a patient and had antibiotics. Exposure to healthcare activities. The same antibiotics he is taking at home, unlikely to get it. But the same antibiotics, prolonged antibiotics inside a hospital is likely to get it. Age and immunosuppression. Gastric acid suppression is also a risk factor. Most of the ICU patients will be put on gastric acid suppression because stress will cause hyperuricemia. So they will be put on it. But still, there is no complete evidence. Most important is your antibiotic exposure. So now, how do you treat medical treatment? Vancomycin is now considered standard care. There is no doubt about it. So, drug of choice is vancomycin. When will you use metronidazole? When vancomycin is not available and patient has got IES. These are the two conditions when you will use metronidazole. I've given you the reasons as statements here. So, vancomycin is the drug of choice. The drug which is the biggest culprit causing pseudomembranous colitis is clindamycin. And metronidazole is an alternative for treatment. So, very quick summary. It's a hospital-acquired infection most of the time. You can get it in the community. It is a gram-positive spore-forming obligate anaerobe, so difficult to culture. Infection can be from asymptomatic to fatal. Especially in an ICU setting and antibiotics, think of Clostridium difficile. So you can look for stool, you can do PCR, imaging may be needed, colonoscopy may be needed. What you do, you stop the initiating antibiotic, which may be your clindamycin, etc. Start on vancomycin. But if there are features of peritonitis or frank perforation, you will consider surgery, or even a toxic megacolon, you will consider surgery. So thank you very much. I'll be presenting other NEET recall questions. And if I feel a particular MCQ needed more depth, I will make a presentation separately on that MCQ also. We'll go deeper into the answer. And as usual, I will ask you to subscribe, share and like, and also join my Telegram channel. Thank you.